All right, good afternoon, everyone. Welcome to the webinar, Implementation Science. What is it and what does it mean for the ending the HIV epidemic? My name is Krupa Mehta. I'm a senior manager at NASTAD on the prevention team. And NASTAD is hosting this webinar through our partnership with the RAISE Hub and the University of Washington. For those of you who may not be familiar with NASTAD, we are a nonprofit association of public health officials who work in HIV and hepatitis programs across the country. We provide technical assistance, training, and support to those health departments and their staff. As far as our role in the Ending the HIV Epidemic, a Plan for America, or EHE, we are the National Technical Assistance Provider funded through CDC. For this initiative. We provide direct technical assistance as well as resources, and we also work as the systems coordination provider for HRSA-funded health departments. Some of the things that we've done for EHE, in addition to providing direct technical assistance, is highlighting EHE successes through EHE Spotlight video series. We also do a lot of peer-to-peer learning that is through our various learning collaboratives. We recently also launched a online learning series for teleprep. And we also host monthly EHE office hours calls for peer-to-peer learning with our partners at NACHO. In addition, we also have several ways that we communicate updates about EHE through our newsletter, our microsite, and our listserv. We've provided TA through webinars and resources on community engagement, self-testing, PrEP access and teleprep, workforce development, status-neutral approaches, and social determinants of health. And as I mentioned, we work very closely with our partners through various collaborations, including this webinar series with the University of Washington Fred Hutch Center for AIDS Research. As I mentioned, NACHO is also a partner of ours. NCSD, CSTE, and many others. Our microsite is listed here for all of our EHE work. So this partnership with the University of Washington CFAR and the RAISE Hub, our goal is to advance the implementation of EHE initiatives through the promotion of evidence-based interventions. And so one of the things that we are hoping to learn from you all is what are your needs around implementation science? So we released a needs assessment, and I'll be putting a link in the chat to that. We ask for you all to share your feedback through that so that we can really tailor webinars, resources, and one-on-one support based on what the needs are of ending the HIV epidemic jurisdictions around implementation science. And then we also at NASTAD provide capacity building assistance to the southern region for EHE around these various topics. Okay, so now I'm going to introduce our presenter for today. Dr. Kenneth Sherr is a professor in the Department of Global Health at the University of Washington. Dr. Sherr's research focuses on developing and testing implementation strategies to support data-driven decision-making and service integration into the primary healthcare framework as a means of increasing the coverage and quality of evidence-based interventions. Dr. Sherr has led the development of implementation science training curricula at the University of Washington Department of Global Health, including the development of the PhD program in implementation science. And he also directs the Implementation Science Core of CFAR, which is what we're talking about today. He received his PhD in epidemiology and also has an MPH in international health and health services. So I will pass it on to Dr. Sherr to kick us off.
Great, thank you so much, Krupa. I'm going to share these slides, make sure that you can see them all right. Emma, those look good to you?
I'm seeing your notes, so switch.
All right. Takes a village. How about now?
Looks great.
Perfect. Well, thanks everybody. As noted, my name is Kenneth Sherr. I'm a professor in global health with appointments also in epidemiology and industrial systems engineering. And so you'll hear that see that I'm really coming from the global health space. But I think that there's a lot that we can cross-fertilize between global and domestic health. My work has largely been focusing on Southeast Africa, which has a much larger HIV epidemic disseminated than here in the US, and quite different health systems and resources. But again, I think there are shareable lessons across the two. And what I'd like to do today is really focus on implementation science, what it is, and from the perspective of ending the HIV epidemic, and really focusing on health departments or EHE jurisdictions as the key organizing and leading unit for ending the HIV epidemic at the state and county levels. What can implementation science give us, or what are some priorities for implementation science to bolster the effectiveness of the EHE efforts? Please put comments into the chat box or questions in the chat box along the way. Emma will help field those and try and respond to those as we go on. So what I'd like to do is really put this talk in two parts. First is to focus on what is implementation science? What is the motivation for implementation science? What is the definition of implementation science as a field of inquiry? And what are some of the tools from implementation science that we can take away and apply for improving EHE efforts? And then I've got a couple of thoughts around some priority areas within ending the HIV epidemic that implementation science could be useful to help bolster or answer questions about. So we like to think a lot in the HIV world about cascades, and similar to the HIV care continuum, there's a cascade for the production of research and translating it into effective large-scale programs. And some of this is by design. You know, research is designed to be a risky endeavor. We take risks, and as colleague Matt Golden has mentioned, it's chaos, where we throw balls up into the air and we see which ones stick. And because of that, we're going to have some research that doesn't pan out. We get negative results. But some of our original research will be effective, and we'll then go through a process of submitting to journals for publication, be accepted, and ultimately published. And then there's a delay in terms of time and the inclusion of research into bibliographic databases, systematic reviews, the production of guidelines, textbooks, et cetera, and then ultimately implementation. And from the perspective of EHE, we're really focused on improving implementation of evidence-based HIV prevention, care, and treatment interventions. And it's estimated that it takes an estimated 17 years to turn just a fraction of original research to the benefit of patient care. So this is what has been coined as the no-do gap, or this gap between what we know works from largely evidence efficacy trials and its application, the do part, its application at scale to lead to population health improvements. Now, these advancements in medical science continue to outpace their application, and I think we've seen this in the previous 25 years in controlling the HIV epidemic, where we continue to have the production of new tools and new strategies that are really not getting out into meeting the needs of the targeted populations. And this has real-world consequences. And on a global scale, we have over 10 million annual deaths for which we have proven low-cost prevention or treatment strategies. We've made tremendous gains in the space of HIV. We still have over 650,000 annual HIV-related deaths. Still have nearly 2 million tuberculosis-related deaths, over 6.5 million preventable child deaths, 300,000 maternal deaths. And clearly, we could do a lot better if we were to apply the known evidence-based interventions that are really cost-effective to drive down mortality at a population level. And I always like to include this pie chart. It comes from a demographic and surveillance site in Fiji, Tanzania. And basically, they perform a census every year and look at outmigration, immigration, and mortality and morbidity at the population level. And they estimate in this environment that They have interventions that are available, that are codified. They're part of national guidelines. There are medicines, diagnostics, and preventive therapeutics available that could address 85% of the disease burden in this population. Now, I don't think it's as dire as here. The United States is not nearly as dire as Fiji and Tanzania, but I think the message is clear. We have the persistent gap between what we know works and its application in a scaled version, and again, it has real-world population impacts. Now, bring it to the domestic sphere in the HIV space. Looking at this no-do gap, we have more than estimated 1.2 million people who could benefit from PrEP, but only 25% of those are actually prescribed PrEP. And amongst those who are prescribed PrEP, then there's questions around continued use and its effectiveness at a population level. So we have a no-do gap in the PrEP space. And we also have a no-do gap with HIV testing. So less than 40% of people in the United States have ever been tested for HIV. And it's estimated that 80% of annual HIV infections are transmitted by people who don't know that they have HIV or who are not in HIV care. So again, we have these evidence-based interventions, but yet they're not getting out to meet the needs of population. And in the context of ending the HIV epidemic, this means we have continued incident HIV infections that we could prevent to meet the ambitious EHE goals. Thinking about the HIV care continuum, looking at the prevalence continuum here, it's estimated that 87% of people living with HIV have been diagnosed, know they're HIV infected. Only 66% are receiving care, only 50% are retained in care, and 57% are virally suppressed. So looking at these data, all these data, the no-do gap is we have the tools in our possession that are part of guidelines and funded right now to achieve the 95, 95, 95 targets. And I would say this is true in the United States, and I would say this is also true globally, but we are just not able to address this no-do gap. Now, it's helpful to look at these aggregate data, but it doesn't really help us understand what we can do to lead to improvements for PrEP administration, for HIV testing, or for the HIV care continuum. And I want to take us to Mozambique, which is where I do a lot of my work. These data, though they come from Mozambique, I think are illustrative of a similar phenomena that we encounter here in the United States, where we have to go beyond the aggregated data to look at the disaggregated data to understand why we are not really hitting our targets for to close the no-do gap and what we can do about it. So there's a program in Mozambique. It's through the Ministry of Health, where they're focusing on continuous quality improvement. They carried out a survey a number of years ago in 32 health facilities that provide comprehensive HIV care. And this was prior to the test and treat guidelines. So this is when treatment was initiated based on clinical staging or CD4 count. They carried out a survey in 32 facilities, pulled patient charts for about 5,600 patients, half of whom were on antiretroviral therapy and half of whom were not yet initiating antiretroviral therapy. And they looked at whether guidelines from the Ministry of Health were evident in patient charts. And you would expect that all patients would have CD4 tests in the last 6 months. All patients who were eligible were receiving antiretroviral therapy. All patients who were eligible would be on cotrimoxazole prophylaxis. And certainly as the most dominant lethal co-infection, that all patients in this setting would be screened for tuberculosis. But looking at the patient charts, the story demonstrates that in aggregate or on aggregate, that the aspiration was not being met with action. So I want to focus in on this TB screening data here, where only 18% of patients in aggregate had evidence of having been screened for tuberculosis. But when you go down to the facility level and you look at those 32 health facilities, and here you see data in the purple bar are those patients who are not yet on antiretroviral therapy, and the maroon bar, those that were on antiretroviral therapy, you see a different story when disaggregating these data. You see that some facilities are doing exceptionally well at screening for tuberculosis. So for example, in the center, you'll see the Shai provincial Provincial Hospital, where 90% of patients who are on antiretroviral therapy had evidence of being screened for tuberculosis in their clinical charts. While you look at other facilities that are similar, and I'll take us over to halfway between Xai-Xai and the far left, Chimoio Provincial Hospital, very similar to Xai-Xai. It's a provincial hospital. Staffing patterns are quite similar. Resources available are quite similar. The level of HIV infection was quite similar, but in Chimoio Provincial Hospital, less than 20% of patients who had initiated antiretroviral therapy had evidence of being screened for tuberculosis in their clinical charts. And when I look at these data, and I work a lot with industrial engineers, and when they see patterns like this, which are quite consistent whenever you look across delivery systems where some facilities or some providers are doing very well and others are doing less well, they see an opportunity for improvement. And what it speaks to me is that context matters. And in the field of implementation science, they often say context is king. Because in some places like Xai-Xai, things are working really well. Other places like Chimoio, they're not working so well. And so the question around context is, what can we do to understand and address the barriers or determinants of implementation in lesser performing delivery systems? And what can we take from the better performing units like Xai-Xai Provincial Hospital, learn from them and transport or transfer throughout the system? Because in the context of ending the HIV epidemic, if we want to meet the ambitious targets of driving down, dramatically driving down by 2030, the number of new HIV infections per year, it's going to require the entire system working well and really meeting the needs of our target population. And it brings to in my mind, a quote from Don Berwick, well, I've heard attributed to Don Berwick, which is, every process is perfectly designed to give you exactly the outcome you get. So in this case, it's a design question, it's a systems functioning question. And if we can redesign processes or systems, we should expect to be able to get better outcomes, and which is going to be fundamental for closing that no-do gap in the context of ending the HIV epidemic. So I'm sure you've all heard of the translational highway or the translational research continuum. It really buckets research into different areas based on intent, where on the far end, we have discovery, which is the T0 or T1s, those first steps of translation, where we're asking and answering questions around mechanisms and targets. We want to define mechanisms and targets, identify new diagnosis, treatment, and prevention methods. This is largely done in the laboratory setting or in the preclinical setting into the clinical setting. The second stage of translation is that developmental stage. These are largely efficacy trials, those phase 3 randomized controlled trials, which are establishing the efficacy of new interventions in controlled environments, also known as going from bench to the bedside. And I'll go to the far end of that fourth and final stage of translation, where we're measuring whether our programs, delivery systems, are improving health outcomes. And here, we're trying to study the influences of our delivery systems or our programs on the health of populations. Now, if we're going to be closing this no-do gap, and we're doing it at scale, we really are focusing on questions of delivery. Questions of delivery, that third stage of translation, are exploring how to deliver evidence-based interventions in real-world settings. I put it up here as the black box of delivery or the black box of implementation, because questions around delivery and implementation are quite complex. We don't really know which levers to pull at any given moment to lead to improved health outcomes or really take advantage of those evidence-based interventions that we know work from the clinical setting, from the development phase of research. I also have heard it referred to as a black box of delivery, because health systems or delivery systems implementation is a costly endeavor and can take quite a lot of resources. And we find ourselves in the context of ending the HIV epidemic with an infusion of resources to take advantage of the evidence-based interventions that we have, but how best to position those resources and deploy those evidence-based interventions is going to be key for us to achieve the improved health outcomes that we want to achieve at a population level. So it brings me to implementation science. Now, implementation science as a field, it's not a discipline, it's a field of research. is relatively new. And the journal Implementation Science came out in 2006. So we're really talking about under 20 years of formal inquiry as a field of implementation science. And there are multiple definitions like any relatively new field of research. So what I'm going to talk through here are definitions coming out of how we at the University of Washington are thinking about implementation science. Again, you'll hear different definitions really focus on a pragmatic, inclusive definition of implementation science as a systematic scientific approach to ask and answer questions about how to get what works to people who need it with greater speed, fidelity, efficiency, quality, sustainability, and relevant coverage. Now, there's a lot, I'm going to unpack this a little bit. We are seeing this as a systematic scientific approach. So we are using the scientific method to hypothesize and research and answer questions about how to deliver those evidence-based interventions in real-world settings. Now, the what works piece means that we need solid evidence on what works. We need data from efficacy trials, randomized controlled trials, to demonstrate that interventions and then later implementation strategies work. And then we want to close that no-do gap, so we're not waiting 17 years on average to take advantage of novel interventions. So we increase the speed, reduce that 17 years. We improve fidelity, fidelity referring to ensuring that the active ingredients of interventions are retained as we are implementing and scaling up evidence-based interventions. And we do it with efficiency, realizing that resources are limited. Quality speaks for itself, that we have an eye towards sustainability, thinking about how interventions will be sustained as we go to scale, and relevant coverage. Realizing that often when we talk about coverage, it's not a monolithic definition of coverage, but we're focusing oftentimes on key populations or subpopulations, and coverage may be in improving coverage within those populations. Now, we also see implementation science really as a framework of methods. And applying methods, multidisciplinary methods. I think one thing everyone agree on is implementation science is a team sport that tries to bring in the strengths of multiple disciplines. As we improve this process, as we go from developing an intervention to implementing that intervention, often on a pilot basis, or as we're trying to beta test how we grow larger, and then to scale up. Because if we do want to lead to population health improvements, we do need to unpack the scale piece. It's great to have something work in a limited environment, but as we go to scale, we're dealing with a broader array of interested parties. We're dealing with more complexity in delivery systems. Resources become more constrained. And we need to have that quality and fidelity of implementation as we go to scale in order to really take advantage or maximize the potential of evidence-based interventions. So we've thought a lot about what are some of those core methods to implementation science, and we've really identified 10. This is not an exhaustive list, but those that we think are really fundamental for building capacity around and applying to delivery systems to close this no-do gap. And I'll start kind of at the top with surveillance and data systems. And we have this tremendous advantage where we have a lot of routine health information systems or data systems and surveillance systems that really can guide not just understanding where there are gaps in our delivery, but then also using them to detect whether our implementation efforts are working well, and then ultimately to understand if they're working well, why, and if they're not working well, why not. Impact evaluation, growing or using those data systems is key, and we can think about impact evaluation from an experimental approach where we're prospectively testing in a randomized fashion in intervention delivery strategies, or it could be quasi-experimental designs using routine data to again take stock about whether our implementation efforts are achieving the impact that we hope they achieve. Economic evaluation is fundamental here, and especially as we're starting to think more about sustaining and scaling interventions and intervention deployment strategies, given that availability of resources is always constrained. And then bringing in from the social sciences qualitative research, really trying to get deeper into understanding motivations for people's behaviors, understanding motivation of providers' behaviors, understanding how and why, as part of a process evaluation, our intervention deployment strategies are or are not working. Operations research, and the term operations research is used heterogeneously. Here, we're referring to operations research from the perspective of applied mathematical modeling. So using, for example, simulation or optimization models or disease transmission modeling to understand how an intervention or how we can deploy that intervention could lead to improved impacts in our ultimate goal, which would be, in the case of EHE, reducing HIV incidence. And building also off of industry or what we do get from large-scale process improvement strategies, systems analysis and improvement, so more bottom-up improvement like continuous quality improvement or quality assurance approaches. Borrowing from more organizational psychology, organizational readiness for change, or understanding where there are opportunities at the organizational level to improve readiness for implementing change as we're discovering and developing new interventions and deployment strategies and bringing them to scale. Stakeholder and policy analysis as a formal method is an area which is, I think, fundamentally important when we're working at the level of implementation, whether it's a pilot or going to scale to new populations. And particularly, we're thinking about sustaining activities, which is a large funding and political component. How can we leverage what we know about stakeholders and the policy development process to sustain interventions as resources become more constrained? And then dissemination research as a formal approach to take novel information or guidelines and actively disseminate that to users and systems, largely going to be providers or those working within delivery systems to deploy interventions in an active approach. So not waiting for diffusion, but actively disseminating information, and then social marketing as an off branch of dissemination research, focusing on demand creation or generation, and really as a fundamental tool for, in the context of ending the HIV epidemic, increasing utilization of our services and evidence-based interventions. Now we think about these as really just a host of frameworks that are, or a host of methods that are important for understanding and improving delivery systems, but how and when you use these methods is going to depend on what your goal is and where you are in that transition from developing an intervention to implementing it and ultimately to taking it to scale. So part of the field of implementation science has been really thinking about studying the implementation process, and then not just studying implementation, improving the deployment or implementation of those evidence-based interventions. Enola Proctor in 2008 came up with at the time a novel framework for thinking about what goes in between developing an evidence-based intervention or practice and assessing client outcomes. When part of this was the development of or identification of the term implementation strategies as one of the key tools for implementation science, which are strategies that focus on implementing the evidence-based intervention in diverse contexts, and they can focus on those they can focus on trying to improve implementation at a systems level. They could focus on trying to improve the organizational dimension that could be a barrier or a facilitator for implementation, focus on supervision, improving learning, or it could focus on individual providers or individual consumers. Now, and if they work well, an implementation strategy should lead to improvements in implementation outcomes, which you may have heard about. And implementation outcomes are those more proximal outcomes to a delivery system, focusing on feasibility of implementing an evidence-based intervention, fidelity. I mentioned fidelity. It's really those core components that have to be there for an intervention to work. Penetration, which is how deeply does an intervention, an evidence-based intervention, penetrate into an organizational setting. Acceptability amongst providers, amongst clients. Sustainability, ultimately uptake or adoption, and then costs. And if implementation outcomes are improved by implementation strategies, it should improve service level outcomes, which are efficiency, safety, effectiveness, equity, patient-centeredness, and timeliness of implementing and the evidence-based intervention, and that should lead to improved client outcomes. Now, typically, research has focused on, does an evidence-based practice lead to improved client outcomes? But implementation science has focused largely on, do implementation strategies improve implementation outcomes? I think as the field has evolved, we're thinking more and more about implementation science spanning across this entire continuum. So we need to be thinking about evidence-based practices themselves. In the context of EHE, that would be things like PrEP, HIV testing, and strategies to deploy those interventions to then lead to ultimately improved client outcomes, but through a process of increasing or improving implementation outcomes to improving service outcomes and then client outcomes. So I've been using the term evidence-based interventions and implementation strategies differently throughout this talk, and that is intentional. Because within the context of implementation science, one of the key notions is that there's a difference between an evidence-based intervention and an implementation strategy. Evidence-based interventions are what we are trying to implement. It doesn't have to be just a biomedical intervention. You see it as what's been called the 7 Ps. It can be a program, a practice, a principle, a procedure, a product, a pill, or a policy that we know improves health behaviors, health outcomes, or health-related environments. So it's not, again, not just a PrEP being a pill. It could be guidelines around how to assess eligibility for PrEP. It could be guidelines or procedures for educating PrEP users around proper use of PrEP or those that improve retention in PrEP. Implementation strategies, on the other hand, are actions that focus on improving implementation outcomes like adoption, implementation, and sustainability of those evidence-based interventions. These are how we try to deploy those evidence-based interventions. So later in this talk, I'll talk more about implementation strategies because I think it is a key area for ending the HIV epidemic to close the no-do gap for EHE. And it's also one of the major tools or areas of inquiry for implementation science and where I think the field has a lot to offer for closing the no-do gap. Another hallmark of implementation science are the use of theories, models, and frameworks. There's a great paper by Nielsen et al. That was published in 2015 that took the myriad frameworks, and there are hundreds of them, and tried to put them into buckets based on intent. How would you use them? And I just want to talk through this briefly around 3 main intents of using theories, models, and frameworks, because I think they can be helpful for guiding data collection. They can be helpful for understanding how you take novel interventions or research findings and you put them into practice in a real world setting. We're helpful for understanding where there are gaps in delivery and then understanding how you can address those gaps. So the first area or intent is around using theories, models, and frameworks to describe or guide the process of translating research into practice. So the intent here, again, is to describe or guide the stages or phases of research translation into practice. These are action-oriented models that provide practical guidance for planning and executing implementation strategies to support implementation. So there's models like the PRISM framework, the EPIS model, or the dynamic sustainability framework that can help implementers and help researchers focus on what they need to do to prepare for and support the translation of research into practical action in real-world delivery settings. The second intent of theories, models, and frameworks is to understand and/or explain what influences implementation outcomes. Here, I'm going to focus on determinants frameworks. So these are frameworks that are trying to understand and/or explain influences on implementation outcomes. So what are the barriers to implementation? What are the facilitators for implementation? Because from an follow-up, what are you going to do about it perspective, it's fundamental to understand what are the barriers or facilitators for implementation, because that will then guide the next steps. So these frameworks help specify the types and domains of determinants that are barriers or enablers. These are the determinants, barriers, facilitators, as independent variables that influence implementation outcomes, the dependent variables. You may have heard of the Consolidated Framework for Implementation Research. This is one of the dominant frameworks in the field, or the Theoretical Domains Framework, or the Active Implementation Framework. But basically, these are guides to structure data collection and analysis to understand and identify those determinants that you would want to leverage or address if it's a barrier as you're trying to improve implementation of your evidence-based intervention. And then finally, evaluation models. These are frameworks that are helpful for specifying aspects of implementation that could be evaluated to determine implementation success. They're helpful for guiding what you would collect and to look at whether or not your intervention and your implementation strategies are having the impact that you desire. And some examples are the REAIM framework, the REACH Effectiveness, Adoption, Implementation, Maintenance framework, the Implementation Outcomes framework, and the Precede, Proceed framework. So the field of implementation science has a framework for you. And the question is ultimately what is the intent of your data collection, and that can guide which framework is most suitable. All right, so I've spoken a bit about the motivation for implementation science. I've spoken about implementation strategies, implementation theories, models, and frameworks. And now I'd like to go into, well, what does this mean for ending the HIV epidemic? So I'm sure you have all seen this. This is part of our U.S. National HIV/AIDS strategy. Our goal is to get to 3,000 annual HIV infections by 2030. That's 7 years from now. And from 2015 to 2018, we were pretty much flat, 36 to 38,000 new annual HIV infections at the level of the United States. It dropped slightly in 2019 to around 35,000, probably due to mostly the rollout of PrEP. But if we want to bend the curve and get down to a rapid acceleration or reduction in new HIV infections per year to hit that 3,000 goal, we're going to have to do things differently. And we're going to have to do things faster and much better than we've been doing. And implementation science could contribute or support this process. First is around implementation strategies. So I've talked a bit about implementation strategies. I'll give a bit more information in subsequent slides on implementation strategies. But from the context of the perspective of implementation strategies, EHE can be a consumer of information around which implementation strategies are effective. Really just writ large, what works from the perspective of implementation strategies in implementing the interventions that we have and we're trying to scale up in the context of EHE. And not just do they work, but we want to understand, do they work under or not, and under what conditions? So I think one of the aspects of EHE is that we are a heterogeneous country. We have a complex architecture of state, county health departments and at the national level, largely at federal level, providing funding. And we have a tremendous heterogeneity in terms of the epidemiologic profile driving the HIV epidemic that varies largely by region, by rural, urban, and urban environments. And we want to understand not just do implementation strategies work, but under what conditions do they work, and how can we make them work in a way which would be transferable to novel settings. In addition, we want to know what they cost. So it's great to show something can work, but what does it actually cost to implement those implementation strategies? Because that's going to be essential for supporting scale up across diverse contexts. So I've got some examples. Around PrEP navigators, which is an implementation strategy. It could become ultimately a guideline, and in many places it is a guideline. We don't have a good sense across different settings of what do PrEP navigation systems cost, and what do we get in terms of implementation outcomes, and then ultimately in terms of reduced HIV infections. So we have a large evidence gap around PrEP navigators that we could fill out that would be advantageous for ending the HIV epidemic. Another question, how can behavioral economic strategies like incentives enhance demand and enhance program effectiveness? There's lots of opportunity to test out new models for supporting the delivery of EHE interventions that come out of the behavioral economic sphere, and in some places incentives are being tested out, but we don't know enough around how well they work in different contexts, and what is the level of support that's needed to make them work, to optimize them, to then lead to improved program level outcomes. So there's a body of literature on implementation strategies in place and continues to emerge. And there's quite a lot of different studies going on now, supported through EHE funding, to develop and test implementation strategies across priority EHE jurisdictions. You can, if you're interested, you could go to the ISKI-3 website, and they have an active dashboard that they continue to look at EHE implementation research investments to bolster the evidence based around implementation strategies. But you should be thinking about implementation strategies from the perspective of what is the barrier trying to address, and how does that implementation strategy address that barrier? So, for example, if you have an information gap, stakeholders are not aware of your program approach, well, then you may want to focus on training and educating stakeholders. That can be conducting ongoing training. That can be distribution of educational materials. That can be use of trainer-the-trainer techniques. If there's a lack of engagement of consumers, on implementation strategies that increase demand or use mass media or involve patients and consumers and family members. So there's a suite of implementation strategies that are out there, and we are getting better at putting these into categories that could then be used to map onto the barriers that you have found that determine the implementation of evidence-based interventions, to try and improve implementation of those evidence-based interventions. Now, just a final thought on implementation strategies. You know, it's helpful to know that the use of patient navigators can lead to an X% increase in uptake and proper use of PrEP. But ultimately, we want to know how and why that works. And part of knowing how and why an implementation strategy works, so that we can ultimately get at the mechanisms through which they work, is better specifying those implementation strategies. So there's also movement in the field, and you'll find more and more publications and synthesized results coming out, including the ISKI-3 dashboard, which I mentioned, where they're specifying implementation strategies and looking at how well they work in different contexts. And ultimately, this is to support transferability of the evidence generated in one setting to another setting. So if we know how, not just that an implementation strategy was deployed and it was effective in improving an implementation outcome and hopefully reducing HIV transmission or incident HIV infections, if we're able to specify on a much more specific level how it was done, who conducted it, what was the intensity of implementation, what was the implementation outcome that was affected, and a strong justification for the implementation outcome, then we can start to improve the transferability of implementation strategies from one setting to another. Okay, a second area that EHE, the implementation science could support the EHE is the scale up to maximize impact. Now, in the context of scale up, we have the notion of spread, where there's this adoption and replication with little modifications within of an intervention within a health system. But if we want to achieve scale, then we really need to be addressing the system and infrastructural issues that arise during full-scale implementation. There's a group called ExpandNet that's out of the World Health Organization, where they define scale up as deliberate efforts to increase the impact of a successfully tested health innovation so as to benefit more people and to foster policy and program development on a lasting basis. And the notion here being that that scale is an intentional process. And the EHE is all about achieving scale. So how can implementation science support that scale-up process? I think some examples below illustrate line of thinking. One is identifying what works to scale up effective implementation strategies while retaining effectiveness when expanding to new populations, implementing through new delivery systems, and given the attenuated oversight when going to scale. You know, much of the research around implementation strategies is done still in a highly controlled environment. And if we're going to scale, we tend to have less intensive support for those implementation strategies. So from the implementation science perspective, it would be helpful for understanding how scale-up processes work and then studying what makes them work better. So an example question could be, how can scale-up planning be routinized in EHE planning and support? So, you know, as local EHE plans are developed, as stakeholders are brought together at the jurisdiction level, are folks thinking about scale up to that last mile from the beginning? And how is that planning being supported? These types of questions that implementation science can help support. So the third area is around sustainment. These data here are from the global health setting, but I believe the situation is similar here in the United States. We have seen a pretty significant increase in funding for HIV control programs. And this figure here, you can see in the red funding, this is in billions of dollars increased for development assistance for health from, this is HIV control program funding, increased from about $2 billion in 2002 to about $8 billion in 2008. And then by 2012 was at $10 billion. So massive increase of funding, and maybe not the same scale, but similarly, EHE has brought an infusion of new resources for ending the HIV epidemic, but is essentially flat. And as time goes on, is decreasing. And we are living in an environment where, given the political and economic reality, we're unsure about what the 5-year commitments or the 10-year commitments for HIV control are going to be. So the question that raises in my mind is how can we sustain interventions and implementation strategies to beyond just 2030, when we're trying to get to 3,000 new HIV infections, to ultimately to full epidemic control. So questions come up around prioritizing existing resources when and if money goes away. And states may or may not have the funds to absorb activities when funding from the federal level decreases. So it'll be helpful for sustainment planning to know which activities should be sustained and in which form. So collecting and presenting cost information is going to be fundamental in this really political process as funds become more constrained. So for example, what is the cost per case of HIV detected? I don't think we know this at a jurisdiction level or at a national level, but it's fundamental if we're thinking about how and what should be sustained given restrictions and resources. And from an implementation science perspective, there's a question around how EHE jurisdictions can position the data that they have and that will continue to be generated to navigate these changing political and economic landscapes. But so sustainment is going to be a really important area of inquiry, and one that that implementation science can help navigate by providing data on things like costs and impacts that are expected to be seen given the different costs of programs. A penultimate issue which I'd like to raise is inequities. Now, we talk a lot about inequities in addressing social determinants of health and public health. And we know within the EHE we have a pretty important and unaddressed inequities when we think about HIV infections and access to HIV programs. So this is also something which is not going away anytime soon. It hasn't reduced really in the past 10 years, and I don't think it's gonna be rapid in the future. But implementation science can start to focus our thinking and research on preventing inequities as really an important aspect of meeting our broader EHE target of reducing incident HIV infections. So we can be asking or thinking about what are the prevalent inequities and are they routinely measured? And if they're routinely measured, great. This is something that will help us to understand whether we're making an impact on inequities. If they're not routinely measured, then what can we measure to get an understanding of persistent inequities in the context of EHE? Are there modifiable determinants of these inequities? Often no, and social determinants of health come with deeply rooted and persistent determinants of inequities that are difficult to address. But if we can find modifiable determinants, then we can start to address those and hopefully address the program inequities within context of EHE. And so then the determinants, as I noted earlier, should map to or can map to strategies to address inequities across the EHE pillars. So just some thoughts about what sorts of strategies can be tested to address inequities in the context of EHE. Do cash transfers improve effectiveness of HIV prevention and control outcomes amongst the most marginalized? And what unintended benefits are observed beyond just HIV prevention and control outcomes? And another is, can directed clinical services improve engagement in the HIV care continuum, focusing on the most marginalized populations? Now, finally, just some thoughts on integrating research or implementation research into local EHE plans. You know, I've noted before, I work mostly in global health, where there's a health system in Mozambique, where I do most of my work, and where research is coordinated through the Ministry of Health. So any new project that I work on with others has to be approved by the Minister of Health and before it receives ethics review or ethics approval. In that same vein, I think about how local EHE jurisdictions really should be in the driver's seat of not just consuming research, but setting the research agenda, participating in research, and then ultimately being the users and disseminators of the research findings. So for this to happen, for research to feed into the EHE targets, we need to be thinking about research or implementation research that is relevant. So in addition to answer EHE jurisdiction priority questions, is fast, that provides results quickly, so it doesn't take 2 years for a publication before the results are feeding into the EHE local plan development, and that is engaged and engages EHE jurisdiction personnel throughout the process. I mean, I'd say the best practice of implementation research at the top of my list is always engagement of health department personnel throughout the process. So how can we build a fruitful platform for health department and research institution collaborations? I think there's a couple ideas that I've been speaking about with Matt Golden, who's co-directs the Implementation Science Core with me here at the Center for AIDS Research at the University of Washington, and also works out of the Seattle-King County Public Health Department. First is shared funding. So we oftentimes create an environment where we have funding for implementation and funding for research, and they're not put together. But is there a way that there could be shared funding that limits indirect costs? So it's not seen as implementation research being antagonistic towards implementation efforts at the health department level. Can we have shared positions? So here in Public Health Seattle-King County, we have medical leadership, we have PhD level EPIs, and we have students who engage with the health department in a formal way. So formally are named leaders in health department programs, or provide formally as part of Public Health Seattle-King County EPI support. And that can really help to create this, instead of antagonism, create this shared objective of trying to integrate research into public health programming. Shared goals. So are there concrete immediate activities to build relationships and that build trust, that build progress towards larger term goals? You know, can we have a conversation between the implementation research community and EHE jurisdictions in such a way that it defines those shared goals and then can work together in a way which is built on reciprocal trust to meet those shared goals? And then ultimately, this is going to require sustained commitment of leadership at both the level of the EHE jurisdiction as well as the research institution, because to create such a platform, to create sustained funding, to create commitment to have personnel shared across implementation and research institutions is going to take the highest level of commitment from leaders within both organizations. So I'm going to stop there. Looks like we have 2 minutes for any comments or questions. Turn it over to other folks.